Dr. Noha, can you hear Dr. Shimaya clearly?
Right, he's speaking right now?
I don't know because there's a very big
No,
problem.
I couldn't hear him.
Yes, let me tell him again. Maybe we can begin. I don't know. This is the first time it happens, to be honest. I don't know what's going on.
Hello everyone and welcome, and apologies. Just give us a few minutes to adjust this stick.
Dr. Joyti, please, can you talk to Dr. Shimaya? If it's going to take longer, I think we should begin. It's already 4:39 and people are asking me the WhatsApp. This is the first time it happens. If we begin, it's better.
Yes. In the interest of time, we will begin this. First of all, hello everyone and welcome. To begin with, we have Dr. Sama as a chairperson today. So welcome, Dr. Sama. Dr. Sama holds a BS in Medical Laboratory Technology from the American University of Beirut and a PharmD in Clinical Pharmacy from the Lebanese American University. She is currently the co-founder and CEO of the Medical Agency for Research and Statistics, which stands for MARS. And after graduation, Dr. Sama held the position as a chief pharmacist at the World Health Organization. Then she has been involved in clinical research, more specifically in trainings and workshops, and carried out at the national and regional level. She's the author of many scientific papers published in peer-reviewed journals, as well as a booklet titled Clinical Research Process from Initiation to Publication. She's an editorial member of 2 peer-reviewed scientific journals and an assistant professor at the University Institute for Nursing. And she's lately appointed as a Global Pharmacovigilance Society Ambassador of Lebanon, where she also acts as a board member of the society. So that's great. It's great to have you, Dr. Sama.
Thank you so much, Dr. Joyti. Thank you so much for the introduction. I'm so happy to be among you. Can you see my screen with the slide Patient Safety Day?
Yes, we can see.
Okay, thank you so much. Welcome all. And I want to apologize for the technical issue that happened with Dr. Shimaya. He was supposed to begin the talk, no worries. I want to welcome you all at this very important day. It is a day where we shall all celebrate healthcare professionals and common people, because at some point in life, everybody on this global earth will use medication, and using this medication will present maybe some harm to them, because medication usage may cause serious harm if it is incorrectly stored, if it is incorrectly prescribed, if it's incorrectly dispensed, if it's incorrectly administered, and if it's incorrectly monitored. In addition to that, the medication usage as well as medication errors, this can cause main harm to patients, and healthcare professionals may someday also be patients. So it is our responsibility to spread this awareness among us as healthcare professionals as well as among people. There are many stakeholders in this issue. Medication error, my slides are only few slides, don't worry. Medication error can be defined as we all know, as any preventable event that may cause patient harm. I will not read the whole because we all know it. And this harm can be really prevented with some awareness, like these events. Medication errors, they can be caused by weak medication systems, where we must work on that, by human factors like fatigue, like environmental conditions, like staff shortages among healthcare professionals. And this can lead to severe patient harm. It can lead to disability among patients or people taking these medications, and eventually sometimes it can lead to death. Therefore, in this context, and especially after the coronavirus breakdown or pandemic, medication safety has been selected as the theme for the World Patient Safety Day 2022, which is this day today. And they have put the slogan, medication without harm. And this is where we are reading all over the slogan, medication without harm. And this Safety Day has 5 objectives. Very briefly, we have to raise global awareness in this issue. We have to advocate urgent action to improve medication safety. We have to engage all the stakeholders, from the healthcare professionals of all types until the patients, until the caregivers like family members, in order to reduce these errors and these medication-related harm effects. We have to empower patients and their families to be actively involved in that. You cannot go hear an excuse from the family member or the patient, I don't know, I just took the medication. And finally, we have to scale up the implementation of the wonderful work of the WHO Global Patient Safety Challenge, which is under the slogan of medication without harm. This is all what I wanted to begin with. Thank you so much for everyone attending this session. Thank you so much for all our wonderful speakers, for giving us the time, for our moderator, for Dr. Shimaya for organizing this, and for all the attendees who care for themselves and other people in attending this event. Thank you, Dr. Jyoti. We can go ahead.
Thank you, Dr. Sama, for wonderful introduction. That was really great. Now we will begin with the chief speaker of the day, that is Dr. Rajesh S. Hire, sir. Sir, are you online?
Hello.
Yes, sir. Yes. So, Dr. Hire, sir is currently working as professor and head of department at Government Medical College, Baramati, Pune. He's having more than 25 years plus experience, and also has contributed to PVPI as a professor, head of the department, and coordinator for the ADR monitoring center at BJGMC. He was also a member secretary of ethics committee and has published more than 20 articles in international journals, and has guided many postgraduate students to accomplish their degree as well as PhD, and is also a DNB examiner. So welcome, Dr. Hire, sir.
Thank you, Dr. Jyoti. Can you project the slides?
Yes,
PPTs?
yes, sure. Yes. Please let me know once it is visible.
Yes. Thank you, Dr. Chinmay, for giving the opportunity to speak at this auspicious event. Dr. Jyoti, next slide, please. Elderly people have individual variability in health, disability, age-related changes, polymorbidity, and polypharmacy, making generalization of prescribing difficult. Medication use in older adults inappropriate and enormous due to the complexity of prescribing. Next. Multimorbid patients are prescribed more medications, increasing the risk of inappropriate prescribing, drug-drug interaction, drug-disease interaction, adverse drug event, and medication errors. It is necessary to ensure safe but cost-effective use of medication and good quality of life in the older citizen. What is most important is cost-effective use of medication, because as the age progresses, these geriatric peoples, they have the limited funds, and whether it's a 65 years or whether it's a 75 years of age, everyone has to go through this phase. Due to this, whenever you are prescribing these medications, especially these geriatric people, they have the multiple morbidity problems. For that, they have been prescribed many drugs in the combination. So chances of drug-drug interaction, chances of adverse drug reactions are more common. And especially if you don't consider these economic problems, especially the cost of the drug, where the pharmacoeconomy plays a very vital part, it should be considered. So in relation to that, there might be the possibility of non-compliance from the patient's point of view. So this cost effectiveness is more important. Next. Some common prescribing errors: omission error, deletion of a drug that is being previously used, commission error, addition of a drug that is not previously used, dosing error, incorrect dose, frequency error, incorrect frequency, form error, incorrect dosage form, substitution error, a drug from one class substituted for another drug from previous same class that is being not previously used, and duplication error, two drugs from the same class being prescribed. Whenever we are prescribing the two drugs from the same class, there is every possibility of additive effect of the drug. Remember that when we combine the drugs from the two different classes, then you have the chances of supra additive effect. Like take the example of spironolactone and furosemide, you have the supra additive effect. But if you combine the two drugs from the same class, like brufen and the aspirin, you have the additive effect. So whenever you are prescribing the drug, you should always consider the class of the drug. Next, factors that previous slide. Factors that predispose to the prescribing errors: individual and team effects, like prescribers' knowledge of medications and patients' comorbidity is more important. Because of the increasing workload, the many times the responsibility is pressed on the junior doctor, which have the where I'm not saying that they have the less experience, and because of which the error might medication error might be corrected. Medication error might occur. Patient related factor: patient's knowledge of their medication, honesty regarding their medications use, and their comorbidities. Next, other factors: excess workloads, as I said previously. Then legibility of prescription, clear explanation for patients and pharmacists. Whenever we are prescribing these drugs, especially polypharmacy with multiple comorbidities to these geriatric patients, you should always explain each and everything to these patients, so that the patient should understand if any adverse effect is occurring to the patient, and he can report to the doctor. Next, pharmacokinetic and pharmacodynamic and prescribing error. Prescribers needs to be aware of physiological changes that occur with aging that affects the pharmacokinetic and pharmacodynamic to reduce the adverse outcomes arising from these errors. The key pharmacokinetic changes associated with old age are as follows. Next, absorption of the drug, increasing gastric emptying time and gastric pH, decrease gastric acid secretion and GI motility. So this will delay the absorption of the drug, and due to the delay of the absorption of the drug, there is increased gastric time. The bioavailability of the drug, especially, it might decrease. Then distribution of the drug, reduce renal and hepatic blood flow, and reduce cardiac outflow. The drug remains in the central compartment. Central compartment means the drug remains in a circulation, and there is less volume of distribution of the drug, especially with the drugs which has got less margin of safety. with such drugs, the chances of drug toxicity is more common. Take the example of a drug like a tricyclic antidepressant drug, imipramine. This imipramine, when you prescribe to these geriatric people which have the more chances of the occurrence of the depression, these antidepressant imipramine, it causes the drug toxicity. Then metabolism, reduce first pass metabolism and clearance, especially the hepatic or renal clearance is decreased with the geriatric people, and because of which, due to the decreased clearance, due to the decreased metabolism of the drug remains in a circulation, especially in the blood, and the chances of drug toxicity is increased in the geriatric people. Then excretion, as I said, there is reduced GFR, decreased renal size and renal perfusion. The chances of drug toxicity is increased. Next, medications error made by the elderly population from the patient's point of view. Dosing mistakes, incorrect dosages, due to the decreased vision of the patient might take the higher dosages, or the patient might take double dose. Administering a wrong medication due to look like or alike packaging, due to the decreased vision of the patient might take wrong medication. Then from the dispensers misuse, taking the correct medicine but inappropriately combined with the food, beverage and herbal medicines. Remember that these geriatric people, they are in habit using the other pharmacy preparations, especially for the constipation. These pharmacy preparations, they are likely to affect the bioavailability as well as the clearance of the drug. So you should consider, you should take the detailed history of the patient, whether the patient is taking the any other medications along with the drug which you have been prescribed to these elderly. Taking the drug that is being expired, it is because of the changes in the memory that has occurred with the changes in the age, storing in inappropriate conditions and over-the-counter use of drugs. Next slide. Forgetting the doctor's or pharmacist instruction, which is very common with the geriatric people. Improper timing, mistaken drug because of the confusion or misunderstanding the general purpose of medication. Next slide. Methods to reduce these prescribing errors. Education techniques for medication errors. Education techniques should be implemented for prescribing training at both undergraduate and postgraduate level. These junior doctors, they should be properly trained regarding the adverse drug reaction, regarding the prescription of the drug. Then targeted at those who make the most common errors, especially the junior doctors. Focus on the areas where errors occur most commonly. Next slide. Verification of all the drugs, both prescription and non-prescription, currently being taken by the patient. Clarification or evaluation of each drug for appropriateness. Reconciliation of new complete drug list with the previous drug list. always remember that because of the confusion, because of the loss of memory, every time you should ask the patient regarding the previous prescription. It might happen that the patient might consult the multiple doctors for his problems, and because of that he might take the wrong medicines. So every time you should consider, you should ask the patient regarding the previously prescribed drug, and you should compare the previous prescription with the current prescription that has been prescribed to the patient. Then transmission and communication of updated accurate drug lists to the next care provider. You should explain regarding each and every drug to the patient, not only to the patient, if the caregiver or the relatives of the patient, if they are along with the patient, then you should explain regarding all these drugs to the patient or the relatives. Next. Then regarding the pharmacist, clinical pharmacist can identify the prescribing error. Remember that the pharmacist is the vital part in this pharmacovigilance program. So they can immediately spot out the error, and they can report the error to the medical teams on how to rectify these errors. Similar to the physicians, clinical pharmacists should have the structured training program in geriatric medicine and geriatric pharmacotherapy as undergraduate and postgraduate. Special training programs should be there to these pharmacists to report these medications error. Next. Insufficient staffing, workload, reduced supervision, poor communication, these are the contributing factors. Encouraging all the prescriber, regardless of seniority, to check all the prescriptions for correct dose, correct formulation, correct mode of delivery is important in achieving a culture of careful prescribing. So work environment is a most important factor. Next, prescribing assessment tools should be there to minimize these medications errors, especially in the elderly people. The Medication Appropriateness Index, first published in 1992, used to assist the recognizing prescribing errors and improve overall prescribing quality in older people. The Beers criteria were the first explicit criteria published in 1991. The stop or start criteria have been emerged alternative to these beer criteria and were published in 2008. Stop criteria to detect and highlight the common and preventable potentially appropriate medications. Start criteria focused on potential prescribing omissions. Next. At present, stop and start are the only set of explicit geriatric prescribing criteria that have been shown clinical benefit when tested by the clinical trials. However, prescribing assessment and optimization interventions have also been evaluated by randomized controlled clinical trials. However, none of them has come into the routine clinical use. This is the limitation. Next. Before conclusion, certain precautions has to be taken in the geriatric people. Make sure that whether the drug is required and whether the diagnosis is made correct. Second, do not prescribe the drug with major side effect, especially regarding the drugs affecting the thinking and the balance, especially the drugs like anticholinergic drugs. which include the drugs for overactive bladder, which is a very common problem, especially in the geriatric people. Then itching or allergy, then vertigo, nausea, nerve pain, depression, where these anticholinergic drugs, they have been commonly prescribed and they affect the thinking and the balance of the geriatric people. Similarly, sedatives and tranquilizers for sleep and anxiety. The drug like alprazolam or zolpidem, they have been commonly prescribed, which affects the thinking and the balance of the patient. Then blood pressure medications that brings the blood pressure, which can that brings the blood pressures suddenly low, which can affect or which can cause the lightheadedness or even the falls, which makes the elder person difficult to stand. So whenever you are prescribing such type of drugs, it is better to start with lower dose and gradually go on increasing the dose, but do not increase it to the maximum tolerant dosages. You should prescribe such dosages to the patient that it will make comfortable to the patient and it will cause the minimum adverse effect. Similarly, anti-diabetic drug. Take the example of the anti-diabetic drug. These anti-diabetic drug, they causes the hypoglycemia, sudden hypoglycemia, and they can cause the multiple problems to these geriatric patients, or they can cause the sudden fall, and which can complicate the further uh, uh, lifestyle of the patient. Then third, do not prescribe the drugs with major side effect like anticoagulant drug or warfarin. Then dose adjustment in the geriatric people or these age-old people or senior citizen is more important. Always start with the low dose and then gradually increase the dose. Dose adjustment uh, depends upon your hepatic and the renal clearance. Then dosage form, use the suitable dosage form, tablet, syrup, injection, and suppository. Then consider the packing of drugs, as the geriatric people, they have the poor vision, so especially the packaging of the drug is it carries more important part in this medication error. Then consider the adverse reaction. If new symptoms appear or if the patient complains of the new symptom, then always consider whether this is a new adverse drug reaction for the drugs which you have prescribed to the patient. Then drug history is also more important, especially the patient is taking any other system of medicine, herbal drugs, or any other medicine the patient is taking, that drug history is more important. Then uh, uh, next, FDC, whenever possible, consider the fixed dose combination to improve the compliance of the patient, because in this fixed dose combination, you will have the more effective drugs, and it will decrease the frequency of administration of the drug, and it will give the better compliance from the patient point of view. Then patient compliance is also important, or it should be considered. Give proper information to the patient regarding the drug. Check the patient's compliance by asking regarding the drug intake. Then whether asking regarding the adverse effect of the drug, you have prescribed the antidepressant drug like imipramine, ask whether there is a tachycardia or whether there is a constipation or whether there is a difficulty in micturition. This will give you the idea that, whether the patient is giving the proper drug history, whether the patient is having a proper compliance with the drug. Then next, discontinuation of a drug, it should be gradual. Like take the example that many times the corticosteroids, they have been prescribed to the patient. A sudden withdrawal, it may cause the Addison's disease. Or antihypertensive drugs, these antihypertensive drugs, they should not be suddenly withdrawn, because if you suddenly withdraw the drug, these antihypertensive drugs like clonidine, alpha-methyl dopa, then there is a bouncing of the blood pressure. The patient might have to admit to the ICU. So gradual withdrawal should be there. That is before, at the starting of the medicine, you gradually increase the dose, and if you want to withdraw it gradually. Then consider the cost effectiveness of a drug, as they have the limited economical resources. Previous slide, Dr. Jyoti. High quality and more effective computer system optimizes pharmacotherapy of older people, particularly to those chronic illness polypharmacy. At presently, 2 European unions funded multi-center trials in preparation will test two similar software systems in their ability to attenuate adverse drug reactions and rehospitalization and composite healthcare utilization. Next slide. The volume of medication error contributes severe public health problem, and among the older people, it's a priority to offer an optimal quality of care. Healthcare authorities, pharmaceutical industries, medical professions, nurses, pharmacist association should include the objective of reducing medication error. Next slide. Next slide. Thank you. Thank you so much.
Thank you, Doctor, so much for your valuable. Can you hear me, please?
Yes, thank you so much, sir, for focusing on the medication errors in elderly, which is often the most important but neglected part. So if anyone has any questions, please feel free to drop them in the chat box, and I'm sure everyone, the speakers will be happy to answer them.
Thank you, Dr. Jyoti. You can hear me? You can hear me?
Yes, I can hear you. I can hear you.
I just want to add something. Thank you for this valuable lecture, because it really sheds the light on a group who are really vulnerable, and any error may lead to death. And unfortunately, in the floors, in the tertiary healthcare, in the hospitals, most of the problems happen at this age group due to many factors: psychological, mental, among this age group, as well as physiological. Thank you so much for the valuable presentation.
Thank you. So the next guest speaker we have is Dr. Nuha. Dr. Nuha is graduated as a Doctor of Pharmacy from Jordan University of Science, which is one of the top-ranked universities in the MENA region. She has worked as a clinical pharmacist in a private hospital and has covered medical assessments for inpatients at critical units and the oncology department for 4 years, and then she moved on to work at the drugstores in regulatory affairs and has fields since 2014. Welcome, Dr. Nuha. It's a pleasure to have you here. So let's begin with the session.
Thank you all doctors for this introduction, and I would like to take the opportunity to thank you all and all attendees, and it's my pleasure to meet you. Let me share the screen, or can you share it, please?
You are the host, you can share it. If you cannot, maybe it's with you, Dr. Jyoti, you have it?
No, I don't have it. Dr. Chinmaya.
Dr. Chinmaya, but Dr. Nuha, you are the host. If you cannot, we can put Dr. Chinmaya. Try, take your time.
Actually, I prefer to share it by doctor because I have
Okay.
a technical difficulty.
But you have to put Dr. Shinmaya as a host. Do you know how to put him as a host? Give him the host. You go to his name, Shinmaya, and click over next to his name. There are 3 dots, and you can put him as host.
Okay, Shinmaya. Can I
Yes.
have the spelling?
Shinmaya, CHIN. Doctor.
Okay.
Yes. Are there 3 dots next to his name? Make host. Okay, Dr. Shinmaya,
Okay.
you are the host. You can you share the screen, Dr. Shinmaya, the slides for Dr. Noha?
I'm doing that now.
Yes, he will do it now. He will do it. No problem, Dr. Noha. It happens all the time. Sometimes we cannot connect and share the...
Okay.
Dr. Shinmaya is dealing with that.
Okay.
No worries at all. Yes, while he is preparing the slides, I want to yes, he is now starting the screen sharing. I just want to mention that Dr. Noha is an expert in her field, and she comes from Jordan, and we are really happy today to share her experience. And she promised me she will be with us in other events, inshallah, right?
Inshallah.
She and her sister, who is also a professional. Okay, you have the slides, and you can tell him for each slide.
Thank you, Dr. Shalmaya, and thank you, Dr. Sama, for the introduction, and Dr. Shalmaya.
Sorry, but please, I just want to ask, can we all mute ourselves, please, because so as not to interrupt Dr. Noha. Please, if we can, yes, if we can mute ourselves. Thank you. Tfaddali, doctor. You have the floor.
Today, I will highlight more and focus more on the quality part, because when we are talking about patient safety, we have to focus also on the quality part that includes the good documentation to track the actual cause of the medication error in order to prevent. So my topic today will be the root cause analysis for medication error, and I will give overview of the needed kappa. Next, please. Next, please, for the next slide.
Next slide, please, Dr. Shinmaya. Okay.
Today, I will highlight more on the quality perspective of the medication errors handling. This quality perspective assists in the actual determination of the cause of error and how to prevent any recurrence for this error. Medication errors definition in general, it's any event that may cause or lead to inappropriate medication use or patient harm. It could be wrong patient, wrong medication, wrong use, wrong route, wrong time, wrong documentation. Errors in a quality definition means non-conformity. I will use this definition in the next slide. Next, please. Next slide, please.
The connection is very bad. You cannot share it from your side. You have to share it. It's better, I think.
Yeah.
Dr. Shinmaya, please, next. Okay.
Okay. The best practice to fix any error is to do a prompt correction for the happened error, and then to specify and analyze the cause of this error. How? Through root cause analysis methodology that we will talk about it more in the next slides. Why we will do root cause analysis? In order to prevent its reoccurrence, to prevent it in the future. We lost the share screen. Can you see it, the share screen?
No, yes,
no,
I think this connection is lost.
Yeah.
Dr. Mo, can you share from your side, if possible?
I couldn't from my side. Dr. Sama, you have it, right?
I don't know, honestly, also because, no, I don't, let me see. No, I cannot. Why you cannot? If you make share, you cannot. If you open it on the big screen in your background, and you can, let me check.
Actually, because I open it from browser, so I don't know what is the technical problem is.
I'm trying from my side. I don't know if it will work.
Yeah, Dr. Chinmaya is online. We started screen sharing.
We are really sorry for the difficulties. Today is a very bad day for connections. It never happened before, really.
Okay, let's go back to the definitions. Root cause, it is a fundamental deficiency that results in non-conformance, which means medication error, which must be corrected to prevent recurrence of the same or similar non-conformance. What's the root cause analysis? It's a systematic approach or methodology used to identify the true cause of the unsatisfactory performance. Next, please.
There is also a lag in the connection. It's okay.
It's okay.
It is worth waiting because the topic is wonderful and nobody has before that really presented this topic. You are welcome.
Okay, what is the root cause analysis step?
He is starting it again.
What is the root cause analysis steps? What are the steps? The first one is define the exact problem. Data collection, document any related info for this non-conformance. Do the investigation by the qualified person to identify the possible factors as per the earlier presentation done by the doctor. Analyze the possible factors, and then we will have the conclusion, which is identification of a root cause. Next, please. RCA methodologies are two, or the main of them are two. The first one is Fishbone, and the second one is 5W2H. We will talk about them in brief. Next, please. This is an example of how we can analyze the root cause through fishbone diagram. We will put the factors of each, the possible factors, and we will describe them in detail in order to come up with the conclusion. Next, please. About 5W2H, the second methodology, we will ask the responsible person with certain questions like what happened action, what are the steps taken, what is the justification of this error by asking why, where is the location of this error, when it happened, by whom. It's not to blame, but it's a corrective action that may need more training, how the error was happened, And we will ask also how much to identify the costs. Next, please. How we can use the result of a root cause analysis to prevent this error happening in the future. There is something in equality called CAPA. CAPA is the Corrective and Preventive Action Plan. This plan includes 4 steps. We will talk about these steps in detail in the next slide. Next, please. The first action after identifying the root cause, as we talked earlier, we will go through a CAPA procedure. After identifying the root cause, we have to do the prompt correction, which is the immediate action to correct the situation. And then we will start in corrective action. What is the difference between corrective action and the prompt corrective? Prompt corrective, it is the correction that I have to do it on a spot. The corrective action, it is the method to eliminate the root cause that may cause recurrence of the same error in the near future, maybe today, maybe tomorrow. Preventive action is the action to eliminate potential non-conformance for the same root cause or other root causes. Test the effectiveness. We have to evaluate the effectiveness of the suggested CAPA. In the next slide, I will give you case study in order to understand more. Next, please. Case study. Elderly patient came with nose bleeding to ER, emergency room. The physician and nurses will start to investigate and to determine the root cause. Physician took the medication and medical history. Patient has Alzheimer and stented on warfarin. Physician expected warfarin overdose during prognosis. Physician requested INR. So after doing the data collection, after doing the needed investigation, the root cause analysis based on the INR result was that the patient took warfarin overdose. Now we completed the root cause analysis step. Next, please. Next slide. What is the prompt action that I have to do to correct the situation? The physician prescribed vitamin K with appropriate dose to correct the situation promptly, which is antidote for warfarin. All of us know that vitamin K, it is the antidote of warfarin overdose. So what is the corrective action to prevent warfarin overdose happening again in the near future? Physician repeated the INR tests after taking the vitamin K, which is the antidote. Physician switched the patient to the safest alternative anticoagulant drug. The doctor reassessed the Alzheimer medication because, as we said, the patient stented on warfarin and has Alzheimer. Maybe Alzheimer is a risk factor that the patient took the warfarin twice. What is the preventive action? All medication must be provided to the patient under supervision of caregiver. Okay, so in the previous slides, we handling the medication error that happened by identify the root cause, set a corrective and preventive plan according to the root cause. Now, after the physician completed the CAPA, he had to test the effectiveness of this plan. The plan was random visit to check if the locker of medication is locked, monitor the coagulation status of the blood via appropriate blood tests, because he switched to another medication, so he used another lab monitoring. Check Alzheimer's status level. Check if the overdose accident happened again, although a caregiver has been assigned. Next, please. Thank you, everyone. It's a short presentation focusing on the quality part of how a caregiver must deal with medication error from quality perspective. If you have any question, please drop it.
Dr. Noha, first, I want to thank you so much. First, I want to apologize for the technical issues from your side and from our side.
It's okay. I apologize also because I have a technical problem. I couldn't share it.
At least we could deliver the presentation wonderfully. Thank you so much for the topic. I really want to mention something. We have been working on so many webinars, so many conferences. Really, since 5 years ago, I haven't attended, honestly, pharmacovigilance workshops related to quality. So the topic, when you sent it to me, I really liked it, and I was so sure that it would be very beneficial. Thank you so much, because we always look at the problem and we present the problems and we just mention in theory, we have to know the cause, we have to mention to correct the cause or the error, but we couldn't have a tool or a way or a structured way, as you said, the fishbone as well as the 5 H's. So thank you so much.
Thank you. And I want to highlight something. Everything must be written on SOP because not all people have the same logic how to analyze the root cause and how to set appropriate CAPA plan. So we also recommend SOP, and we can talk more with another webinar in the near future, inshallah.
But I want to ask you something. Do you think that this root cause analysis system is really implemented on institutions? I think some institutions do not carry out this. They just,
in hospitals, it is to take the accreditation. You have to implement the needed SOP and to review it every certain period of time, and to have a quality department. Actually, it's implemented in some hospitals, example, the hospital I worked in and the drugstores, but we don't, we hope to implement this system in all hospitals.
Yes, this is what I want to say. Thank you so much from my side. Dr. Jyoti, if you have anything to add, thank you so much for your time, for your input. It was very valuable.
Thank you.
Thank you, Dr. Noha. Thank you, Dr. Noha, for emphasizing
Thank
it.
you.
So to begin with, I would like to introduce our next presenter, Dr. Vivek Singh. He's a dental surgeon working as a drug safety specialist with 7 years of experience in pharmacovigilance domain as a medical reviewer for aggregate reports and signal detection. Additionally, he has 2 years of experience as a signal expert trainer. Hello, Dr. Vivek, and welcome, and it's glad to have you. Hello.
Hello. Am I audible to all of you?
Yes. Welcome, Dr. Vivek. It's a pleasure to have you.
So thank you, Jyoti, for a warm introduction. And I've shared my screen. Could you please let me know if it is visible to all?
Yes, it is visible.
Yeah. So before starting this presentation, I just want to wish everyone a happy patient safety day today. It has been a pleasure that I would be presenting this topic to all of you. And so my topic of discussion today is presenting an overview of medication error in general and clarifying some of the common misconceptions in PV background. So in today's agenda, I would be basically covering an overview of medication errors. What is its statistical relevance? Secondly, common reasons which are associated with medication errors, which causes medication errors. What are the different strategies to prevent medication errors? Please be attentive. There are a couple of questions that I would be posing to you all. So please be attentive. There are a couple of questions, and later part is references. So let's begin with understanding of medication errors. So as the definition is already clear, it is unintended failure in drug treatment process that leads or has a potential to cause patient harm. So this definition is basically from EMA website, and it is from good patient guide. It is taken from there. So basically here, what is the take is that medication error is always unintentional. This should always be our main aim, that medication error are always unintentional. Secondly, it could happen at any stage of drug treatment process. That means it could happen at prescription stage, it could happen at dispensing stage, it could happen at administration stage, or during prescription time. So it can happen in any stage of drug treatment process. So if it is not clear, so there is always a chance that we will make a coding error, and we might get confused between what medication error is, what misuse is. So having a clarity of what difference between medication error and what misuse is very important. Please note, medication error is always unintentional. Misuse is always intentional. Misuse is inappropriate use of medication, and it is always not in accordance with what is there in product information. Although medication error is also not in accordance with product information, however, it is always unintentional. So takeaway of this slide is that medication error is always unintentional in nature. So now we have understood what is medication error, and some of the clarification regarding some of the common terminologies is already covered. Let us see what is its gravity, how much it is there worldwide, how much cases are reported worldwide. So if you see in FDA reporting, there is 1 lakh reports which is submitted every year from FDA. Medication error, it accounts for it is at least 1 death occur every day in US. In India, there was one study which was conducted in Delhi, and which accounted that medication error occurs with an incidence of 34%, and ADE was reported at 8.2%. So I've already provided the references. If you are interested, you can read those articles. That are very useful articles. So medication errors, more than 1.3 million people every year are reported with medication error in US. So these are important facts that come into picture from medical error perspective. So here what is the take is that, as we know, there is always under-reporting developing countries. So these numbers may be misleading. There is actually a large number of medication error which is actually happening in market. If you see developing countries like India, where medication are given from over-the-counter as over-the-counter drugs. So it is always a chance that the patient may consume it and he may suffer from ADA, which may be propagated as medication error. However, he failed to report those cases. So there are n number of cases which are happening as a medication error. However, understanding what medication error is prerequisite, and it is very important. So now we have understood what medication error is and what is its gravity. Let us understand what are the reasons of medication error. So basically, there are n number of reasons for medication error. However, it is not possible to cover all the reasons in a single presentation. So I've collated some of the common reasons that occur in routine practices. Some of the common reason is, first is poor handwriting, which is already covered. So if you see, this is a prescription which is given by a physician to a patient. Here we see the writing is not legible. Here the product information, if you see, it is not, we cannot make out what it is, what is the frequency, what is the drug name, what is the investigation given here. So if you just try to read here, it is given that investigation is for HIV. If at all it is for HIV, the patient might be immunocompromised. And again, there is, and since the drug name is not legible, there is always a chance that the chemist may misinterpret the data and provide an unnecessary medication, erroneously giving unnecessary medication to patient. So this becomes a cause of causing harm to patient. So in support of this poor handwriting, there is a certain data which is already populated. Like in 2011, British paper reported that 10% of the handwriting prescription contained error. 10% is, mind you, very huge number. While in 2006, reported by National Academics of Science Institute of Medicine, US alone reports around, doctor writes around 3.2 billions of prescription annually. And it has been reported that 7,000 deaths has been occurred due to medication error, which is a huge number. So poor handwriting, it has to be taken care of by all the doctors, not only juniors, seniors also. And while we are educating patient, we should verbally also make them aware how the drug need to be administered, how what is drug of, so that patient is much aware, and such errors are neglected accordingly. Now coming to second type of common reason that can account for medication error, that is look-alike and sound-alike drugs. So in market, there are various drugs which look alike and sound alike. So common examples is hydroxyzine and hydroxyline. So here you can see the names are very common, very similar in nature. And again, if you see that, if you see the bottle also, it is quite similar. So if at all both the drugs are there in house, there might be chance that patient might unintentionally take the other medication which is not indicated to him or her. Second is, you can see this here, that both of the drugs, levocetirizine and levothyroxine, the drug size is similar, drug shape is similar, the tablets seems to be same as removed. So any questions from anyone? I thought someone has unmuted. Okay, so here you can see the drugs are similar in nature. You can see the shape of the drugs are similar in nature. And we often see in developing countries, the drugs are prescribed loose. So the drugs are of various sizes, various shapes. So always there could be a chance that patient might intentionally take another medication. Why? Because drugs were looking similar. So, and also the drugs are sounding similar. So in sounding similar case, the patient might take another case, or in case, and in that scenario, he or she might be harmed from that drug. So look-alike medications, there are various n number of examples which are available on public domain. One of the example is mercaptan and mercaptan. If error occurs of this site, it can reach to patient and may result in harm. So it is quite often that the linguistic property between the names and it can cause a potential for error. It has a compounding factors. So basically, whenever a drug is, so this needs to be taken care of while it is being dispensed by a product, by a prescriber, or else by company, that not to product seems to be sound alike or look alike product, so that there is a confusion in patients while it is being administered. So this was the second common cause of medication error. Let us check the third common cause of medication error, which is packaging error. So this is a classical case wherein you can see this is a drug wherein there is one missing dose, missing tablet here. And this is an oral contraceptive drug, and there was a missing tablet here, which was noticed later, which was noticed by physician. It was which was noticed much later. And along with that, there was also the drugs were not arranged in proper chronological order. So as we know, the oral contraceptive, there is a proper scheduling done for oral contraceptive, wherein the patient take medicine as prescribed as per the schedule. In case, if at all there is a missing, or in case if he's taking any placebo, and in case there is a contraception, there is the occurring. So there might be a chance that there may be failure of the drug and she might get pregnant. So this is a classical case of one of the, this is basically a classical case study for one of the Canadian pharmaceutical company wherein there was a packaging error which occurred due to defective packaging, and by which if and also there was defective in arrangement of drugs. So the scheduling taken by a patient would be quite different by the one which should be actually be he or actually she should take here. So that might create a problem, and that is a type of medication error. So it is a very wonderfully given in FDA site. I would request all of you to please go through this case study, which is available for one of the pharmaceutical company for packaging error. So this was the third common reason for medication error. So any questions till now for the first three common reasons? Anyone from a team? Participants? Okay, thank you. So last, this is also one of the common reasons by which medication error occurs is that poor communication between clinician and patients. As we know, in developing countries, mostly in developing countries, there are lots of patients which are seen by a single doctor, which is called mass practice, where a single doctor sees lot of patients. So there is always a chance that he whenever he is seeing a lot of patients, he might be in hurry, and he might not be able to convey in rush some of the important information to patients, or like prescription error can occur, or while communication is not so optimal that patient understand what and when the drugs needs to be taken. In hurry, it mostly happens. So this becomes very important whenever a doctor sees a patient. It is important that he gives much enough time to his patient so that his patient is aware. Remember, there is always a ill to a pill. So while giving a pill, the doctor should be aware, and whenever he gives any pill or drug to any patient, he should at least explain him when the drug need to be taken, when the drug need to be stopped, so that he doesn't be in limelight and just using medication as and when he thinks it need to be done. It is not correct practice. So that is the reason poor communication between clinician and patient becomes pivotal in causing medication error. So now we have understood what is medication error, what are the statistical relevance of medication error, what are the common reasons which are associated with medications error. Now let us see what are the various strategies to prevent those medication errors. So I would be basically covering the standard practice that awareness and reporting is very important. Stimulating and encouraging and sharing medication error both nationally and locally. Basically, reporting those cases is very important. In developing countries and other countries, the cases reported are very less. So though we are not aware, in that case, there is always a chance that this error will keep on repeating again and again. Once the number of reporting is more, there could be a definitive trend analysis that can be done, and as already conveyed, when appropriate CAPA action can be designed and necessary action can be taken appropriately for that medication error. Encourage system and provide a targeted feedback so that appropriate preventive strategy can be developed and implemented in facilities. So along with that, a standardization of classification system for collection of medication error. So as we know, the reportings are different in different areas. So there should be a standardized way of reporting those cases so that we collectively get those cases, and a way can be designed accordingly so that we collectively design a way so that this medication error can be tackled upon. So this again, during various stage of medication error, standardization of process, during procurement, during prescribing, during dispensing, administrating, and disposal. Encouraging shared responsibility and to enhance the medication use to minimize the potential for human use. Promote encourage safe use and understanding the technology of prevention of medication error is very important. Increase awareness of need for distinctive packaging and labeling. Always explain patient that this is a leaflet. Please read this leaflet properly before taking this medication so that medication error does not occur. Appropriate nomenclature of product is pivotal, because if nomenclature itself is wrong, there is always a chance of causing a medication error. Educate your consumer, educate patients regarding strategies to prevent medication error for both prescription and non-prescription medication. Again, not only giving medication is important, educate healthcare professional how and what are the main causes of medication error, so that they are much aware and they themselves can strategize and prevent those medication error from their end. Not always theoretical will work. There could be some cases that can be handled by individual physician. However, they must know that what type of medication error is there and accordingly how it can be mitigated. So any questions on strategies to prevent medication errors? Any questions?
Not so far, Dr. Vivek.
Okay, thank you. So, yeah. So coming to questions to audience. Now, as there was no question from anyone, I would definitely want to have pose a couple of questions, not more than that, so that we are on the same page. My basic intent in this pharmacovigilance presentation was that we understand what medication error is and what
sorry, Dr. Vivek, you have a question. Someone typed a question.
Sure.
Yes, they are asking how to report medication errors. How to report them.
So basically, there are helplines whenever you take a drug from any drug. Suppose X is a pharmacological company. Whenever you take a drug from any of the companies, and and medication error is already happened. You have taken levocetirizine. Levocetirizine was a drug which was prescribed, and you have taken levothyroxine, and you have been reported with an ADR. So in that case, there is a helpline number which is given by a pharmacological company. There you can report. It is very easy. You can report by email. You can report by various methods which are already there on their site. You can go to their site and you can report it accordingly. So first of all, you can also, in that case, one more clarification here would be that you can go to your physician and report it. Physician would be someone who would be better positioned to report it directly to the authority, so that necessary action can be taken and the reporting can be done accordingly. Is the answer appropriate?
It is very clear, and yes, thank you so much.
Yeah.
Thank you, Dr. Vivek. You have another question. Is off-label use an intentional error or unintentional error?
Sure. It is coming up. It is in my question. Yeah, it is coming up. So now we have understood some of the basic concepts. So before posing the question, I just want to elaborate what we have learned so that you can just think and then answer it. We have learned what is medication error, what not is medication error. We have understood what is difference between medication error, misuse, and abuse. Off-label use I have not clarified yet. I would be posing while the answer is being given by audience. We have understood what are the common reasons. We have understood what are the proposals. We have understood the strategies. Let us understand through a couple of questions. So my first question to audience is, and it would be a request from anyone, you can just unmute yourself and answer it. If at all it is wrong, it is fine to be wrong. No problem.
Yes, sure.
It's a forum to be wrong. No problem. So the question one is, a physician prescribed a levocetirizine tablet to a 5-year child for rhinitis. As per label, levocetirizine 5 mg film-coated tablet are indication in symptomatic treatment of allergic rhinitis and urticaria in adults and children. Is it a medication error? Please read the question properly. Take 5-10 seconds and you can answer it. No worries.
Yes, it is a medication error.
Could you please explain why it is a medication error?
Medication error.
Inappropriate age would be going as an LLT for this.
Age professional.
Okay. Any other answer?
I think there's a need for combination drug.
Combination drug. No, the question
Yes.
is it a medication error? The question is it a medication error?
Yeah, it's a medication error definitely, but
Mhm.
the prescriber should prescribe one more drug in additive to this levocetirizine.
Okay. So you are answering it's a medication error. I will take your answer as medication error. Any other answer?
I don't think it's a medication error. I think it's a medication misuse.
Can you please explain why it is a misuse? My definition of misuse.
Because it is for the indication, but the wrong is the age. So it is the same indication. Okay, we are at the same track, the right track, but the use it wrongly. This is it. Regarding the age.
Yeah, you're partially correct. Any other answer? Any other answer?
I would like off-label use of medicine, sir. Yes, sir.
Yeah,
It is
why
off-label
off-label
use
use?
of medicine. Because, sir, the
It
drug
is
is
a
used in
dosage form error.
Sorry, two people are talking at the same time. Please, can you repeat?
Sir, ma'am, it is an off-label use because the drug is used in inappropriate to the
Yes.
patient.
Misuse.
No. Is it off-label use or misuse?
Off-label use, sir.
Off-label use. Okay. Why? Because it is indicated for other population, correct?
Yes,
Okay.
yes, sir.
Any other answer?
It is a medication error.
It's a medication error. So it is a classical case of off-label use. Why? I want to give a rationale here. Why? First, it is not intentional. It is so first of all, it is because here the indicated population is different. Okay, indicated population is different. 5 years and 5 years or less. And
Yes, sir. It
secondly,
is already mentioned here in the
Correct.
question. So,
correct.
yes, the doctor is intentionally prescribed to the patient.
Correct. So it is intentionally prescribed for the patient. It is not unintentionally prescribed. Remember why I have focused on unintentional in nature. Because if it is unintentional only, then it will be called as medication error. And that is the reason I have directly focused on it. Now, let us tweak this question to another scenario. Suppose this drug was indicated to adult population, correct? It was given for an adult population as per your label. Okay? It was given for adult population. And that adult has given to his child. In that scenario, will it be a medication error?
Yes, sir.
Yes,
Yeah.
sure.
Yeah.
Sure.
Why?
Yes.
Why?
Because the improper dosing of the drug.
No. Because it is unintentional.
Intentional, because it's intentional, definitely.
It is unintentional.
Because it is unintentional. Because
Unintentional.
he is not aware.
Unintentional.
He is not.
Yeah.
Yeah, because he is not aware this drug should not be used for patient. Right? He's not. Since it is slightly tricky, and that is the reason I have just directly focused on it. Remember this example. You will always remember this concept. Okay?
Okay.
Am I clear?
Yes. Are all your questions for your students like these?
No. Now, second question. Yeah.
Okay.
A physician prescribed a levocetirizine 5 mg tablet to an adult for hypothyroidism. However, his writing is illegible. Thus, in confusion, chemists give levothyroxine 50 mg, 15 mcc tablet to a patient. Is this a medication error?
Yes, sir. It is a
Yes.
medication error.
So what type of
Intercepted
medication?
medication error.
Yes, sure.
Which prescription medication error? Correct.
Yes,
The-
intercepted.
Last.
Correct. Yeah. So now it is quite evident and quite clear. I'm pretty confident that you would be you understood what medication error is. Basically, medication error. What happens without the concept? There is over-reporting or under-reporting of cases, and people are not understanding. And while we are cumulatively assessing those cases, it becomes very difficult for for providing assessment per se. So it is very important that we understand what medication error is and what not it is.
Yes.
So these are the references that I've used. You can go through some of the case studies which are there in references. It is very useful and very easily given there. So thank you. Any questions from
Dr. Vivek, really a wonderful presentation. Thank you so much. And what makes it special is the use of the evidence-based statistical data, as well as the real-life examples of medications like blisters, prescriptions, and the cherry on top of the cake. The wonderful thing were the last two questions. Really, thank you. The way you present things, the wonderful slides. Thank you so much, Doctor. It's really wonderful.
Thank you.
I don't know if they couldn't have time to take the references at the end. I don't know if you can share only the last slide at least with people, or send it to Dr. Jyoti so that they can take the references. It will be wonderful, because a really wonderful presentation. Thank you. Thank you for your time.
Thank you, Dr. Vivek. It was really a wonderful session, and I hope everyone enjoyed and learned a lot. So I would like
Ma'am, I want to ask a question to Vivek, sir. If you permit, then I will ask a question.
Yeah, sure, Alicia.
Yeah.
Sure. Dr. Vivek.
So my question is, for example, cut the tablet before using it, and that cutting is not described in a labeled document. So it is an example of medication error.
Yes, tablet splitting would be the correct LLT for this.
Classical example of medication error. Why? Because breaking of a tablet is classical example, and it occurs in India, and there is a under-reporting of it. Yeah.
Yes, sir. Okay. Thank you, sir.
Okay, thank you, Alicia, for the question. So I would like to introduce the next speaker, Dr. Joanne. She is a regulatory intelligence expert and item writer at the Institute of Pharmacovigilance. She is a freelance pharmacovigilance and medical writer, passionate about both, and is a chairperson of Switzerland and Austria International Society of Pharmacovigilance chapters. She is very active at the European Medical Writers Association. Pharmacovigilance and medical devices are special interest groups. Also very active at the risk communication, geriatric medical devices, and eco-pharmacovigilance special interest groups. So Dr. John, everyone is glad to have you as a speaker. Please proceed.
Sure. Thank you so much for having me today. Thank you very much, Mars, and as well as Dr. Sama and Dr. Chinmay Mahapatra for having me today and giving me this wonderful opportunity to speak. So I'm truly grateful to everyone. I don't consider myself as an expert in RMP and risk management plan, but I am quite passionate about it. So I just would like to speak, and it would be more like a discussion, and I'm a facilitator. So let me share my slides with you. Just give me 1 second. Okay, first of all, I would need the sharing rights, right? I mean, so that is important. Can I get the sharing rights, Dr. Jyoti?
Yes, sir.
Okay, okay. Tell me, can you see my slides, Dr. Jyoti and everyone? Yeah, Dr. Sama, can you see my slides?
No, not yet. I'm not able to make you a co-host. Dr. Sama, can you help?
Can you give me the co-host rights? Okay.
Just a second.
Can you see my slides now, or
yes,
not yet?
Yes.
Okay. Okay, give me 1 second. Can you see my slides now?
Yes, I can see.
Okay, very good. Okay. So we know that at the end of a clinical trial, we know very little. And we know that primarily know more about the efficacy, but almost nothing related to safety of the drug, especially at the end of a clinical trial. But we'd like to use like real world evidence, and we see that a lot of people who get excluded during clinical trial, in fact, are present during when the drug gets administered after the drug is out in the market, especially like underrepresented groups such as elderly, pregnant population, and also population with other diseases. And that could be like, as we are all talking about patient safety day to day, how critical that could be, and with all the medication errors. So RMP and risk management planning becomes so vital. A plan during, especially how we can govern these drugs and how these adverse reactions start populating. Also, many drugs develop the adverse drug reactions, especially later, because new risk keeps emerging because of wider range of population use and long latency of certain drugs. Also, we don't know whether certain headaches, for example, certain headaches are due to drugs or due to diet or regimen. So that is also so, that line is so blurred. So that is why risk management plan becomes very, very important in order to manage these risks. Especially in EU, companies are required to submit a risk management plan to the European Medicine Agency when applying for a marketing authorization. So especially in the EU, it is a required part of the marketing authorization application for all products, almost all new products. Can you go to the next slide? Yeah. So let's talk about certain history of EU RMP. EU legal basis was introduced in 2004 and came into force with revised legislation in 2005. So unfortunately, the 2005 legislation was not very clear in which specific situation risk management system is required. So it actually stated, so wherever appropriate, the risk management system would be applied. So again, we had a revision in 2010, and then more information was introduced in 2012. And gradually, there was a big revision in 2017 where we had GVP Module 5, Revision 2. After that, the RMP became more rational and more risk proportional. So now all companies now applying to European regulators must include an RMP in the dossier supplied for evaluation. We'll go to the next slide. Now, so what is an RMP? An RMP, as I mentioned, it's a risk management plan for any new drug or any updated new drug, which includes information on a medicine's safety profile, measures taken in order to prevent or minimize any harm to patients from the medicine, and plans for studies and other activities to gain more knowledge about the safety and efficacy of the medicine. It also so we are not only taking into consideration the safety concerns which develop during the risk management plan, but we also have a plan to how to evaluate the safety and efficacy of the medicine and how to measure later the effectiveness of these risk minimization measures. So it is basically a detailed description of a risk management system of a drug. And it is regularly reviewed and it is updated as new information becomes available. So the aim of the risk management plan is to document the risk management system considered necessary to identify, characterize, and minimize a medicinal product's important risks. So we'll talk about what are these risks as well. So the RMP is actually regularly reviewed by the EMA, or European Medicine Agency's Pharmacovigilance Risk Assessment Committee, and it is approved by the Committee for Medicinal Product for Human Use, which is CHMP, before marketing authorization is recommended. So now, why is the RMP so important? And it is important because the benefit of a new drug should always exceed the risk, correct? And the risk-benefit balance, that's why, should always remain positive. So the benefit of a medicinal product must not just exceed marginally, but it must outweigh the risk. It must always exceed, and it should exceed by the greatest achievable margin. So here, that is why it is important in order to assess the risk of a new drug. So when is a risk management plan actually prepared? In EU, in the European Union, companies, as I mentioned earlier, must submit an RMP to the agency at the time for a marketing authorization, for a request for approval of a new drug, during application for a marketing authorization, whenever there is a significant change to the benefit risk profile. As I said, benefits must always exceed risks. And whenever there's a new indication, a new patient population, or anytime during the request of the EMA or any national competent authority, or as a result of an important pharmacovigilance or risk minimization milestone being reached. So what does an RMP actually include? An RMP basically includes three specific areas: the safety specification, that also says the safety concerns of a drug, a particular pharmacovigilance plan, and third is a risk minimization plan. So what is a safety specification? It is basically nothing but identification or characterization of the safety profile of a medicinal product, with special emphasis on only important identified and important potential risks and missing information. And also on which safety concern need to be managed proactively or further studied. During the pharmacovigilance plan, the idea here is to characterize and quantify clinically relevant risk and to identify further new adverse reactions. So here we are trying to plan how to implement these pharmacovigilance activities in order to characterize and quantify clinically relevant risk. And finally, we also, after planning, we have to implement some measures in order to reduce these risks or minimize these risks. And not only not to just implement these risk minimization measures, but also to evaluate the effectiveness of these risk minimization measures, which we undertake during the risk minimization plan. So what are the definition of these safety concerns? So we have various risks here: identified risk, potential risk, and missing information. So what are identified risks? They are undesirable clinical outcomes. So here we are not dealing with, we are dealing with clinical outcomes, and for which there is sufficient scientific evidence that they are caused by the medicinal product. During potential risk, we are not, there is yet the causality has to be developed. So they are undesirable, again, clinical outcomes for which there is scientific evidence to suspect a possibility of a causal relationship. There is still no evidence that there is a causality, but there is a suspicion out here. So where there is currently insufficient evidence to conclude that there is an association between the risk created and between the drug. The next is the missing information. Here we are talking about risk refers to gaps in knowledge about the safety of a medicinal product for certain anticipated utilization or for use in particular patient population, for where there is insufficient knowledge to determine whether the safety profile differs from the characterized so far. So here we are talking about pregnant population or people who are dealing with renal failures, or there is missing information here that why there is certain anticipated utilization of these drugs or insufficient knowledge where they have been excluded in clinical trials. So what are the steps involved here? So the steps involved is, there is in RMP, we have a general overview of the medicine, then we have safety specification, then we have pharmacovigilance plan, then plan for post-authorization efficacy studies, risk minimization measures, and finally we have summary of the RMP and certain annexes. So this is basically the risk management plan, where the first is the product overview, then we have the safety specification, then we have the 7 steps in safety specification, and finally we have the pharmacovigilance plan, and as earlier mentioned, the post-authorization efficacy studies, then the risk minimization measures, and how we summarize all this entire risk management plan and certain annexes to the risk management plan. So basically in product overview, we talk actively about the substance information. We are basically talking here about the active substance information, such as the pharmacotherapeutic or the name of the drug, marketing authorization applicant, a brief description of the product, whether it is centralized or whether it's mutual recognition, decentralized, national, so also pharmaceutical forms and strengths. In the second is the safety specification, where the focus is primarily on the safety profile of the drug, where we consider there's an adequate discussion on the safety profile of the medicinal product with focus on those aspects that need further risk minimization activities. The first step in safety specification, we consider, first of all, the generic medicinal product. So the safety specification is same as that of the reference product or of other generic products for which an RMP is in place. And the second is advanced medicinal product, which are the gene therapy medicinal products or somatic cell therapy medicinal products and tissue engineered products. So what do we consider here is the epidemiology. That is the first step that we consider, is the incidence or the prevalence or outcome of the target disease, as well as the relevant comorbidities, and also the relevant for assessment of safety and risk management to be stratified by age, gender, and ethnic origin. So here the emphasis should be on the epidemiology of the proposed indication in the EU, and basically the text should be kept concise, and it should not include any element of a promotional nature. The next is, in an RMP, we also consider the non-clinical part of the safety specification, where we provide high-level summary of the significant non-clinical safety findings of the drug. So basically, we here consider the non-clinical, such as the toxicity or safety pharmacology or other toxicity-related information or data. Where the non-clinical finding could constitute an important potential risk to the target population, it should be included as a safety concern in RMP module S8. So the next is, we consider the clinical trial exposure, where we actually provide a pooled data to the regulators about not just individual trial, but pooled in an appropriate format at the time of the submission of the initial RMP, or when there is a major update due to a new exposure data from clinical studies, example, in a new indication or a new pharmaceutical form or route of administration. So data is supposed to be presented by individual trial when there is a major update due to new exposure data from clinical studies. Otherwise, it is usually pooled. So, so the next slide is, when we are talking about here, next is about the population not studied in clinical trial. Here we talk about these are population that are considered under missing information. We spoke about them earlier, such as pregnant women, breastfeeding women, patients with renal impairment, hepatic impairment or cardiac impairment, populations with relevant genetic polymorphisms, or immunocompromised patients and population of different ethnic origin. So if there is evidence that use in excluded population is associated with an undesirable clinical outcome, then the outcome should be included as an important potential risks. The next slide is again about post-authorization. We also include the post-authorization experience of a drug. And here we are talking about the post-authorization experience in other regions outside EU, where the product is already authorized or from other authorized products containing the same active substance from the same marketing authorization holder. And the data should be also discussed in this RMP module. So, and this year, basically, we are also giving an overview of experience in the post-authorization phase that is helpful for risk management planning purpose. So the next slide, we're talking about additional EU requirements. Now, in additional EU requirements, we are talking about potential for misuse, as we spoke about that earlier, potential for misuse for illegal purposes, and where appropriate, the proposed risk minimization measures are included here. Example, limited pack size or controlled access program or special medication prescription. The last is also identified and potential risk. We also discussed here on the identification of important identified and important potential risk and missing information, or which are also considered as safety concerns. So here, basically, we are talking about, as we spoke earlier about them, about identified risk and potential risk. And potential risk could be also potential from overdose or potential for risk resulting from medication errors. We discussed about that. Or also potential for transmission of infectious diseases or potential for off-label use. Then we finally also gave the summary of the safety concern. Here we are talking about, again, the important identified or potential risks. And we are talking about important missing information. And what are the important identified risks? Important identified risks are those risks that can impact the risk-benefit balance of a medicinal product. And important potential risks are when further characterized and if confirmed would have an impact on the risk-benefit balance of the medicinal product. So this is again related to frequency, severity, seriousness, and outcome of the risk. Then we have the pharmacovigilance plan. With the pharmacovigilance plan, we are talking about includes also post-authorization safety studies. And here we are including also routine pharmacovigilance activities as well as additional pharmacovigilance activities. Finally, we also give the summary table of additional pharmacovigilance activities. So the next is about what are routine pharmacovigilance activities. The routine pharmacovigilance activities are minimum set of pharmacovigilance activities that are conducted for all PV activities. So this is something which has to be, this is not included in the PSMF. So PSMF, whatever is described in the PSMF or pharmacovigilance system master files are not required to be repeated in the RMP. This is something beyond adverse reaction reporting and signal detection. So that could be specific adverse reaction follow-up or questionnaires or enhanced passive surveillance system or high-level description of the enhanced passive surveillance system, observe versus expected analysis, and cumulative reviews of adverse events of interest. So basically here we are tackling with any special request from the health authority that form a part of the standard clinical practice, even like recording of tests. So anything beyond adverse reaction reporting and signal detection. In the additional pharmacovigilance activities, in pharmacovigilance plan, we are targeting clinical investigations such as sentinel sites or drug event monitoring, also post-authorization safety studies. So basically any special request from health authority that is outside of the standard clinical practice. And basically each and every safety concern will have to be monitored, and we use both activities, routine and additional pharmacovigilance activities. Now, post-authorization efficacy studies are nothing but they're imposed. I mean, marketing authorization holders are also welcome to do voluntary post-authorization efficacy studies. But here we are including imposed as conditions or specific obligations to the marketing authorizations, and or for exceptional circumstances. So that could be non-clinical studies and clinical studies, interventional and non-interventional, as well as case control studies or cohort studies. So these are all imposed to marketing authorization holder as a specific obligation. Now, after planning, what we primarily do is also risk minimization measures. So in risk minimization measures, again, we have routine risk minimization activities and we have additional risk minimization activities. So under routine, we have a summary of product characteristics that we have to have for every new drug application or any NDAs, package leaflet, labeling for inner and outer carton, pack size, legal status. These are all routine risk minimization activities or routine minimization measures that need to be carried out, or legal status or restricted medical prescription or subject to special medical prescription. And then finally, we also evaluate the risk minimization effectiveness, and then we have a risk minimization plan. And finally, we also summarize the risk minimization measures in our RMP. So we have here a summary of product characteristics and package leaflet. And basically, we also have legal status that we are trying to control the prescription here, restricted prescription as well as special prescription. And then control studies. We also have control distribution and educational material, patient monitoring cards are given, as well as training programs. Finally, we include the summary of the RMP, which includes key elements of the RMP. And what does it include? Basically, it is basically a summary of important safety concerns and missing information, such as routine and additional risk minimization measures and additional pharmacovigilance activities. Summary of the RMPs are usually publicly available on the EMA website together with the EPAR, or the European Public Assessment Report of that medicinal product. And nationally authorized medicinal products are publicly available on the Nationally Competent Authority website. And then we have the annexes here. Annexes are RMP applies to more than one. If the RMP applies to more than one medicinal product, usually it would be expected that the annexes will be relevant for all products. So we have here various annexes to a single RMP, because RMP is basically a very active substance document, or a single substance document. So what are the responsibilities of the marketing authorization holder? He has to review the RMP with the first 5-year renewal, and the second that is mandatory, and in the time period also when the first PSUR following the first 5-year renewal is due for submission. That is usually 8 to 9 years after the new drug application has been submitted. As a RMP is basically the risk proportional document, so we are only here focusing on important identified risk, potential risk, and missing information. We don't consider all the risks which are all adverse reactions which are reported and all clinical outcomes, only those which are important identified risks, which have an impact on the risk-benefit balance of the product. Again, we also say that RMP is a dynamic document. What do you mean by dynamic document? RMPs are, this includes addition of safety concerns where required, but also as the safety profile is further characterized, the removal or reclassification of safety concerns. So it is a very dynamic document. It is a risk proportional document, and companies are obligated to always submit an updated RMP. And I also mentioned here that RMP is an active substance-based document. That means a document includes all relevant medicinal products from the same applicant marketing authorization holder containing the same active substance. So each RMP will have one active substance, but it may have many medicinal products. As I mentioned earlier, a marketing authorization holder has an obligation to provide an updated RMP. So that could be a change in the list of whenever there is a change in the list of the safety concern, or whenever there is a new or significant change in the existing additional pharmacovigilance or additional risk minimization activities, or there is a change in the study objective or population, or at the request of EMA or an NCA, or when there is a new information being received that may lead to a significant change to the benefit risk balance, or addition of a new safety concern in the key messages of the educational materials. So whenever there is a new milestone being reached, the marketing authorization holder is obligated to provide an updated RMP. So basically, for the purpose of RMP in pharmacy, basically RMP aims to evaluate the risk at regular intervals in response to the progress of post-marketing surveillance to minimize the risk of drugs. So this is a very iterative process, and it is an active dynamic document, as I earlier mentioned. So in order to find out the careers in as a for a PV or an RMP in EU. I mean, here people work as aggregate reporters. I'm sure that it's all over the world the same. Associate in clinical data management, or as a safety scientist, or you can work as a PV writer. As also you can do some additional work as a drug safety associate. So basically, to summarize, the risk management system is nothing but it identifies, characterizes, and minimizes a medicinal product risks. And a risk management plan includes all the existing potential and missing risks. And pharmacovigilance plan, we have to handle this risk. And then we also have the measures to prevent and minimize risk, and we evaluate the effectiveness of these measures. And thank you very much for listening to my presentation, as I'm very passionate about RMP, and thank you so much. And if you have any questions, feel free to ask. Thank you.
Thank you, Dr. Joan. That was really a delightful and wonderful presentation. Yes, any questions from the delegates?
Dr. Joan, I want to thank you so much for the wonderful presentation. Really, in maybe I think half an hour, you summarized very beautifully and in details. Imagine, summarized in detail the risk management plan. Your passion is really evident in the slides. You are an expert in the field. Don't say that you're not an expert, really. And you have talked a big part, which is interesting for the industrial pharmacy. Okay, so we really thank you. You shed the light on many things. I learned a lot from this presentation today. Thank you so much, Doctor.
Thank you.
Thank you
very much for having me. Thank you.
Thank you for your efforts. Thank you.
Thank you. Thank you for having me. Thank you so much for listening.
Thank you. Dear Dr. Jyoti, I think this is the last presentation for today, right?
Yes, last presentation. So any questions from the audience, delegates?
If Dr. Chinmaya, we didn't hear his voice today because due to technical issues, we really apologize from that. And he was all the time with me on the WhatsApp, apologizing from all the audience. He is online or no? I can see the name, but
yeah, he's online. Dr. Chinmaya, are you on? I can see.
Dr. Chinmaya, we want to hear your voice. We cannot live without you. I love him. I love Your connection is not okay, doctor. We cannot understand. The voice is also lagging. It's okay. It's okay. It's okay. Dr. Jyoti, right? I cannot hear his voice. It is lagging and stretching.
Yes, we cannot hear. So
it's okay, no problem.
There's one question from the audience. What should be done in our college as a first year postgraduate MD student? So, if Dr. Hire sir or Dr. Vivek, please, Joan, can you please take over the question? Hello.
This question is presented to Dr. Joan, I think.
Oh, okay. So is it related to RMP? Then I can talk about that. I don't
think so. I think it is related to the career at the end, the last slide that you mentioned, the careers in pharmacovigilance. He is asking what should be done in our college as the first year postgraduate MD pharmacology student. How can he enter the field of pharmacology, pharmacovigilance?
That's a kind of a good question. I feel there should be we need to have some extra lessons here, extra courses, especially if you are trying to pursue a field or pursue your entire career as an aggregate reporter. I can talk about that. Then I guess it's really important that each and every the university students must know what are these specific documents. Because it is very difficult for students when they suddenly get exposed to all these new reports, how you have to write them. So it's important that they need to know right from the start what is the significance of these specific documents and how you can learn more and more. So I agree with completely that the courses need to start right from the first year if you're trying to pursue a career as an aggregate reporter. Otherwise, it becomes really a sticker shocker, right? In order to learn everything right from the beginning when you graduate.
Thank you so much for your wonderful input and your wonderful reply. Thank you all. Dr. Joy, the last presentation, right?
Yeah. Dr. John, there's one more question. Who is responsible for writing the RMP?
I mean, here a lot of in EU we have a lot of medical writers who write RMPs. There are aggregate reporters who write RMP. That could be one of the. I mean, if you are interested in pursuing that field, then I think you need a special training in that area.
Yes, Dr. Sama, any inputs?
Yeah, any other inputs from other specific specialized people here? You're muted, Doctor. You're muted, Dr. Sama.
Yes. You're on mute, Dr. Sama. You're on mute.
Sorry, I am very sorry. Excuse me. Someone is asking. Currently, I am learning VG-Flow. Will it help? VG-Flow.
Sorry, I don't know what is VG-Flow. I may have heard about it, but I mean, I would also like to know more about VG-Flow. What does it inculcate? Anybody here else who can answer this question? What?
It is, Doctor. It is a web-based ICSR data management system. Yes.
So
it is a data management. Yes.
Dr. Abhishek, Vivek here. Actually, VG-Flow, as we know, it is a UMC monitoring center wherein the reporting of ICSR are done. So from ICSR per se, yes, definitely, it would definitely help you. However, since you are pursuing MD physician, you would be MD physician in a couple of years. So there are lots of opportunity as a drug safety physician. And there is opportunity in being a medical advisor. Medical science liaisons is one of the booming field right now, along with PV background. So VG-Flow will definitely help if your interest is in ICSR background. So important question here is your interest. If you are interested in ICSR and long career in drug safety physician, definitely it would be useful.
Yes, exactly. Yes. And it is found in the national pharmacovigilance systems of each country. Yes. This is all for today, Dr. Jyoti. This is all for today, and we don't want to keep our attendees more. We already crossed the 2 hours. I will let you close the day, but let me say something. I want to thank Pharmacovigilance Society for making this event happen and this day, celebrating this day. On top of that, I want to thank Dr. Chinmaya for all his efforts for organizing this event. Our wonderful speakers, who I think we are now one family. We and the attendees, we are one family in this field. We can always interact with each other, take the opinion of each other. We have the names of each other. So thank you so much, everyone. And thank you for assigning me as the chairperson of this event. It was an honor for me, and I will always be happy and remember this day. Thank you. Dr. Jyoti, you can close the session now. You are muted, dear. You are muted, Dr. Jyoti. we should do something regarding this muting thing.
Thank you, everyone, for sparing your precious time. And thank you for all the guest speakers for all the wonderful presentations. Thank you from the bottom of my heart. Thank you.
Thank you all, and see you in other events, inshallah. Bye-bye.
Thank you. Bye.
Bye.
Everyone, thank you so much.
Thank you. Thank you so much. Bye-bye.
Thank you so much.